Welcome to Chapter 4, The Complete Health History. The objective of this is just to present to you my thoughts and ideas about the organization of the health history. I hope you'll find this helpful for your assignment. You're going to have one written assignment where you're going to write up your health history plan, and then you're going to have a recorded assignment where you perform a health history with a volunteer. So let's begin. The purpose of the health history is to collect that subjective data that contributes so much to our understanding of a person's health. So 85% of what we know and understand about a person's health is actually obtained through a history. So the questions you ask and the way you ask them are very important to getting a full picture of a person's situation. And the better you are at listening to your client and collecting this data, the better able you will be to support their ongoing health. Now, one thing you should know is that the sequence of this can vary, and also, although we call it a complete health history, the components that you collect very much depends on your clinical setting. I understand this, and you, I hope, will take and gather the components that you need to expand your own clinical practice. So be thinking about this and what you could do in your particular area of practice that would better encompass the needs of your patient by expanding the way that you collect data, subjective data, from your patients using a history. This is the sequence of the health history, and this is the way that it is always recorded. Now, I recognize that sometimes the way you gather data is different from the way that it's reported in the chart. So be aware that it's very important that we standardize the reporting of this in the writing in the chart. And most of you are using electronic records, so this will already present in this sequence. But be aware of that you do not necessarily need to collect the data in the same sequence that it's documented. And because of the vast way that nurses practice and the many, many settings that we're involved in, the focus of your health history can vary. Most of the time in my situation, I focus on the main concern that the patient has when they come in. However, some of you may be practicing in different settings and you have your own agenda in collecting that history data. I think that it's always important to address the patient's needs and their concern first. And this is part of the way that we can express our nursing value of social justice, by treating each person as a unique individual with their own background and understanding of their health. And so by addressing the person's concern first, you are saying, I value you as an individual, I want to understand more about you, and you're not just pressing on with your own concerns and needs related to their care. Now remember, we understand those needs and we hold those in the background even as we listen and understand and respond to individual clients and their own health concerns. Biographic data is generally present in charts through registration. The source of the history is important and can vary in the setting. If you're working in pediatrics, the source is often a parent or guardian, and you want to think about how much does this person actually know the person that they're providing the information on. Sometimes we run into this challenge with an older adult. Say a family member from out of town comes in and it's giving you information that may be less reliable than an older adult who actually lives with a family member. That person might have more nuanced details about the individual's health. So be thinking about the reliability and credibility of the person who's providing the information. And usually we note those circumstances in the record. Remember, when we do a chief complaint, which I believe is a great starting point, we use the person's own words when we describe the visit. And then we also may give specific symptoms and signs that the person has. The subjective information is provided in quotes, and the signs or the objective information are things that we might observe and see and report. So it's not a diagnostic statement, and it focuses on their prioritized reason for presenting for care. So we collect it, and we can do this in 8 or 7 characteristics, and we collect it in a precise and accurate way. I find that most RNs are very limited in how they collect that history of present illness data. And so it is my hope, and one of the objectives of this course, that you'll expand your interrogation of a symptom. And so that is a value and an assignment in this course. Whoops, we went ahead, but here's those clinical characteristics. And there's 2 mnemonics. We're going to specifically talk about the PQ, RST, and U, but there's another one called old carts, onset, location, duration. Old carts tend to be a medical perspective. PQ, RST, U tends to be a more nursing focused mnemonic, but they are all getting at these clinical characteristics, including the location of the presenting system, the character and quality of it, the quantity and severity. This is usually used with scales. This is the one that RNs are great at, the 1 to 10 scale for pain, for example. And then there's the timing. So when did this start? How long has it gone on, and how frequently it occurs? The setting of the presenting symptom, what makes it better or worse. And the P here stands for palliative, or which is better, or provocative, which is worse. So sometimes we have to force our everyday language into these mnemonics. Associative factors, any other concern, we tend to get to that aspect with the review of systems, of body systems, and their perception of it, how it affects them, or what they understand as the cause of that. And that is a very important patient-centered condition that really helps us as an RN, because when we understand what the patient believes about their condition, we can either educate or we can confirm with that client and help them. It can help us, because sometimes their understanding is spot on, and so it's a shortcut to our understanding and interpretation of their symptom too. Other times, unfortunately, people's understanding may be more culturally based and less clinically based, and in that case, it's important to identify with that person's understanding, but it also gives an opportunity for education. So be aware of those differences too. So here it is again, the PQ, RST, and U. And then, so which of the following is a good example of a well-written chief complaint? Patients complaining of chest pain and tightness, notice that's in quotations, for about 3 days. That's worse with activity and relieved with rest. Pain is 10 of 10. Patient complaining of chest pain, rule out MI. And patient states, I don't know what this pain is. It's the worst pain I've ever felt. So the correct answer here is number 1. It's described in the patient's own word and includes some precipitating and alleviating factors, which leads towards the HPI. May have also been attracted by the 4th option. However, that one's a little too vague. You see, it doesn't really, the patient, it may be a good starting point, but more is needed for you to distinguish that. So I tend to like this number 4 because it is a little more descriptive of the patient's concern. But notice that the better answer is number 1. So number 1 combines some aspects of both of these concepts. But, let's just rule out number 3. Notice that includes a diagnostic statement, rule out MI. So that's not a chief complaint. And then this is the severity of a symptom, but it doesn't really give it in the patient's own words, even though the patient may have reported it as a 10. It's just not descriptive enough, as is 4. So number 1 is the best answer. Okay, let's go to the past medical history. The main thing we want to do here is focus on specific pertinent information, often related to the chief complaint. So there are some contexts where the RN gets a complete past medical history, but part of the critical thinking that's involved in this course is selecting the pertinent past medical history. And we know that that is much more challenging than just collecting it all. But what we do in most nursing settings, we're much more focused. And so you'll need to think about what the specific pertinent information to the chief complaint may be. And because this will also provide cues on how the person may cope with illness. In other words, a person with a chief complaint, they may come in and if they've never had any medical history, this is their first experience with a problem, they're going to react very differently than someone who's had chronic health issues and this isn't their first quote unquote rodeo. So just be aware that that is some of the benefits of collecting the past medical history. It includes childhood illnesses, accidents, chronic illnesses, hospitalizations, operations, obstetric history, immunizations, allergies, and current medications. I especially find the current medication component extremely important in the way you collect this information. For example, many people have prescribed medications. These even may auto-populate on the electronic health record. It's very important that you ask the client themselves how they are taking those medications. This can create a lot of problems. In my area of diabetes, many people can have multiple diabetes medications prescribed. Their physician or prescriber may actually believe that they're taking all of these. However, when you interview the client, you will quickly find out that they do not take their medications as prescribed for many good and some not so good reasons. The problem is in a hospitalized situation, if you as the RN give the client all the medications as they have been prescribed, you may place the person at extreme risk for hypoglycemia. So understanding the current medications and how they're really taking them is essential to the RN role. This also includes medications for hypertension, as people do not usually take their medications, in my experience, as prescribed. And so when they go into a clinical care environment, they may be at risk, especially in the first 24 hours, of experiencing hypotensive crisis or falls, because RNs who do not take a good medical history related to medications may quickly find out that that they are over-medicated if they were to take all the medications that have been prescribed for them. So please be aware of that. Genetics and genomics are a fascinating newer component of health history. However, that genetic testing can often be expensive, and the health history can give you many clues into a patient's genetic risk for diseases, many of which we know to have strong genetic components. And here's an example of a family tree and how that's drawn out. You may see this in medical records, especially of people who have seen someone in internal medicine. The family tree is often underutilized in today's healthcare environment. However, there are specific conditions where this could be very beneficial. New immigrants, it's important to understand folks that or who are part of an immigrant community. They may have very different health expressions, and so we need to understand their perceptions, and especially as this relates also to nutrition. Review of systems is a graded component of our course. Once again, we're going to be focused on the pertinent data, a cephalocaudal approach, which we in common language call a head-to-toe assessment and organization. The review of systems provides a great opportunity for health promotion, for understanding what the person is doing related to those different body systems, or what they are not doing, an opportunity for education. And so we we may not use a complete review of systems, but what you should do is think about all the associated body systems related to a chief complaint. So this involves quite a bit of critical thinking to do it well. So here's a systems approach. We start with their general overall health state, skin and hair, and then we go head, eyes, ears, nose, mouth, throat. Then we go down to the breast, axilla. We focus on these body systems for indications related to their health, respiratory health, cardiovascular, peripheral, GI, urinary, musculoskeletal, neurologic, hematologic, which is often overlooked, and the endocrine system, which is my favorite, another system that's often overlooked. So we focus on that gender related to indications then on male and female genitalia and sexual health. Now, a functional assessment is usually used in areas where people may have developmental differences or in the older adult. So in this case, we're wondering, are they able to do the activities they need independently, safely in their particular care setting? And so we look at things such as their living environment. There's various screening tools for these. And these are very RN focused kinds of care assessments. You often will not find these in a regular chart, but these are areas of nursing influence. So the more we assess the functional assessment of an adult, we can have our own independent nursing practice related to these habits. And here's perception of health. This is important. Again, RN can confirm people's perceptions, or we can provide insight and other perspectives on their perceptions if we think that those perceptions are unrealistic. Obviously, these same approaches are presented in a child as well, but it's adapted to their particular situation. I've had a child myself that fell off the growth chart. And so this idea of nutritional data as it relates to growth and development is essential and sensitive. I know that I personally didn't respond well to this news, and however, I am very thankful that our pediatrician addressed his concerns with me. So just know, even though particular information is not always welcomed, it is important to address and part of your professional role. So then we look at the past health history, and remember that you do need to communicate with that child as well as the adult that's with them. And so there's a unique skill and challenge related to working in pediatric health. And there's details that are also in your book here. We pay special attention in the pediatric time period related to immunizations and communication about those with parents, and then obtaining information about medications, including herbal remedies and other things that parents may be doing related to a child's health history. So we use the same organized approach. We use the PQ, RST, and U, and we do focus also on cognitive and other developments, because childhood is a time of rapid change. And so there's specific differences in that assessment. And however, there are the functional status of a child. We look a lot at screen time with children and the other activities that they are engaging in, relationships with peers, management of stress. All of these are important related to a child's health. And then with adolescents, we have another assessment mnemonic, which is called the HEADS. And in this case, it stands for home, environment, education, employment, eating, activities, drugs, sexuality, suicide and depression, and safety from injury and violence. So adolescence is a time of particular health risk. And so these are areas of inquiry that the RN makes in their assessment of the adolescent. So thanks again for joining me with Chapter 4. This is a very important chapter that will benefit you no matter where you practice. So I want to challenge you to consider this week one area of health history that you can expand on in your current clinical practice, and then take that slight change in your practice and use it to benefit your patients in whatever area you're practicing in at this time. Thanks again. Bye.